Thank you for staying with TV3. This is The Key Point. It comes your way every Saturday at 7 in the morning, where we talk about the most pressing national issues. And this week, or the past week under review, two major issues have dominated discussions. We've closed a chapter on one. The next chapter we are opening has to do with the health of the country. First of all, we've struggled since 2019 with the coronavirus. It has had its own implications on our economy, and then also on the most important bit, the lives of the citizens. Then the last few months, we have been hearing of the cases of the Marburg virus, which has claimed 2 lives. We're told that in excess of about 90 people have been quarantined to ensure that they are better monitored, and contact tracing is also keenly underway. Whilst we are working on that, there is the monkeypox, which has also, infected a number of people. And the fact that it has even been recorded in Ghana has raised quite some concern. We are told that there is a possibility of some vaccines to deal with it. However, it looks as if the earlier we are able to nip it in the bud, the better for the citizenry. The Ghana Health Service, we are told, is quite stretched when it has to do with ensuring that the safety and the livelihood and health of the citizens is guaranteed. What can we do as citizens to help our health institutions and people in key areas, stakeholders, in having a healthy Ghana? That's our conversation for this second chapter of The Key Point, which is live from our studio here at Adesanwe in Accra. And you would also know that Niche Chocolate Drink is our key sponsor. I want to say a big thank you to them. And as I mentioned, we are happy you're having breakfast with us, watching us from your homes and probably in your office. But if you have kids around, you'd want to grab the Niche Chocolate Drink for them. Taste of Ghana, that's their tagline. And I can guarantee that, look, honestly, I've had a taste of it myself. My son loves it, and you should grab it for your ward as well. And for yourself as well, you can enjoy it. It is healthy, and it is one of the reasons why we are talking about health issues. This time around, though, it's one that has concerned many. Let me quickly introduce my guests, then we can delve straight into the conversation. On my immediate right, we have Professor Fred Newton Binka. He is an epidemiologist with the University of Health and Allied Sciences, UHAS, and is one of the known voices when it comes to these kinds of discussions and education. Good morning to you, Prof.
Good morning.
Thank you for joining us. On my extreme left, we have David Tinkran Chum. He is the General Secretary of the Ghana Registered Nurses and Midwives Association, very instrumental in healthcare delivery across the country. Thank you very much, Mr. Tinkran Chum, for joining us as well.
Thank you.
And we have on Zoom, we've been joined by Dr. Titus Bayo, the General Secretary of the Ghana Medical Association. Doc, good morning, if you can hear me, and thank you for making time to join us.
Good morning. Good morning to Prof. and David in the studio.
All right. To start with, later, hopefully, we may be joined by Dr. Franklin Esiedu-Bekwing, who is the Director of Public Health with the Ghana Health Service, to at least, when he does join us, we'll seek his thoughts on what our current numbers are and how we are working to ensure that the general population is safer. But I would want to start with you, Professor Binka. From what you said, what are the key issues that we need to start putting in place immediately? Clearly, we've not been able to prevent the Marburg from coming into our shores. We've not been able to prevent the monkeypox from coming into our shores. News broke of other countries recording them. We thought we could put the right barriers in place, but unfortunately, we've recorded our cases. Whilst we're still trying to iron out or streamline the challenge we've had with the COVID-19. But what is it that we can start doing immediately to nip it and prevent a spread of it?
So thank you very much, and thank you to my colleague panelists. I think it's a little bit frightening to see these 3 big, if you were a tourist, you see the 3 big cats, having COVID-19, having monkeypox, and then now we are looking at the Marburg. In fact, the one that frightens me most is the Marburg. Today, I think it's the most deadliest disease on earth. because even Ebola has a vaccine. Marburg has nothing to support it. So in our part of the world, I think the major thing that we need to put in place is to strengthen our surveillance. At the moment, it's clear that, yes, you can look at it in both ways, that maybe our surveillance from the COVID has enabled us to be able to detect the monkeypox and also to detect the Marburg. But when I asked my colleagues who are in the field, and I actually do most of my work from Howard in the Volta region, we have to give credit to the Ghana Health Service team that did some work in most of the regions, which raised the awareness about the fact that about Marburg, Ebola. I remember your station even reported that there was a new Ebola.
Yeah.
But these were all measures taken to ginger up the surveillance system that led to the detection of the Marburg. Our current system of looking after the whole country in a way that post-COVID, in a way, has been a passive system of surveillance. So we are there, we have the structures around the country, but we wait till there's a case. I think what we need to do immediately is to go into the active surveillance. So for example, in those regions where Marburg has been detected, there's a need to go and do mass seroprevalence to find how many people are actually seeing the virus. Because if you have ever met the virus, we can detect that in your blood. And the tests are not so expensive. So we need to do that, and we need to do that very quickly and make sure that we are ahead of the virus rather than following it. So at the moment, they found the cases, they've looked at the contacts, but if we want to follow the actual path, the epidemiological path, then every contact and his contact and his contact and his contact, and that will widen the scope. So that is one. We need to strengthen our surveillance. Secondly, I don't think there is been enough public education. And if we are in the posture of waiting for the cases to be announced, then we need to improve on the public education. Not only the public education, but also we have to look at the health workers. You know, we have to be able to conduct meetings in all the regions, bringing the districts and the district heads and the surveillance officers together and informing people about the signs and symptoms. So the Marburg one really worries me because we are saying that it might be coming from a fruit bat. But how did it just get into one human being? And when it does that, it's not a worry. It's when it goes from a human being to the next human being, then it's out of the bag. We can't control it anymore. So we don't seem to have put this all together in a way that is meaningful. So that is the second point. The health promotion bit must start critically, and you must be educating our nurses, our laboratory people. We have to put in together our reagents and so on to be able to test this whole process, the samples that will come. We have to up the game on what samples we collect and so on, because the symptoms are not so different, apart from the fact that you have the hemorrhagic part of it, where people are bleeding and having blood in their stools and so on. That the public will rise up to if they are well educated about. So that's the third part. The fourth part is that we need to have a lot more discussion about this, rather than it seems to have gone very quiet.
Yeah.
And we are waiting for the bomb to explode in several other places before we start. And we're not hearing from our Minister for Health.
Especially on these two.
Yes.
It's been very low-key. But I like your submission and your your first few statements on this. Would want to come back and look at When the coronavirus, for instance, broke out, the numbers were huge. The rate of spread was quite alarming. Then it caught the globe's attention, or the worldwide attention. But for this one, the numbers are relatively few. But even on the back of that, they say for it to have been able to, like you mentioned, move from one person to another individual is a cause for concern, and we need to start interrogating. We'll come for you to talk to us more about maybe even the mode of transition from the bat to human and then to other humans. Let me bring in David Tinkuranchum, General Secretary of the Ghana Registered Nurses and Midwives. Professor Benka mentioned public education and awareness creation. How much sensitization would you say our nurses have been given? Because they are clearly the front line when it comes to this kind of exercise. Are they pretty much aware of this, and what's the level of education they have?
All right. Good morning to you, and good morning to revered Professor. It's a pleasure sharing the platform with you. And good morning to my brother on the call. Yes, it's absolutely important that we look at some of these things. Of course, when COVID reared its ugly head, we were able to put some structures in place, and we should be able to capitalize on that. As to whether we are effectively educating the nurses and midwives is another thing. And I think that we need to direct resources to that aspect. Public health funding is expensive. Sometimes you may not see the impact immediately, but if we wait for a very long time, we create a lot of problems for ourselves. So as far as I'm concerned, not enough education has gone on, despite the fact that, the COVID opened us up to some of these emergencies. To add to what Prof said, in fact, Beriberi is a very dangerous disease. Okay, it's highly virulent, and the case fatalities are quite high. As we speak, we've had about 3 people who have been infected, and we have lost 2. That gives you about 66.7% case fatality rate, which is terrible. So we need to move as quickly as possible. And as Prof said, active surveillance is the only way out, because community engagement is the surest way out to be able to surmount some of these outbreaks. Because if the community are not aware, we don't have clear-cut case definition for people to be able to identify whether they are health workers or whether they are even ordinary members of the community. We will have problems. But if we have clear-cut case definition, when it comes at maybe the primary level, maybe at the community level, or at the health center or the CHIP center, the community health nurse, the disease control officer will be able to identify certain basic signs and symptoms that will urge the person on to refer to appropriate quarters for the right attention to be given. If we don't do that, then we're going to have issues. That's why the fact that it's not as infectious as compared to, let's say, Ebola, because of the mode of transmission. Prof will lay more emphasis on it. It's still dangerous, okay, because of the case fatality rate. So we need to improve the awareness, and of course, nurses and midwives occupy the fulcrum around which the health sector revolves. And since majority of them get to meet patients on daily basis, if we're able to educate them and educate them well, it will help the fight as quickly as possible. We'll be able to deal with the issues head on instead of waiting for the thing to engulf us.
And not just the health professionals, but almost every ordinary Ghanaian needs to know about this virus. And you mentioned the cases of how fatal it is. Let me bring in Dr. Titus Bayo now. Doc, thank you once again for joining us. We've had commendations from across the world about how we manage the coronavirus as a country. Would you agree with those who say we seem to have been caught unawares by the Marburg and the monkeypox entering our shores? Or did it come up or generate from here itself? From what you said, what happened? How come we are recording these cases when we seem to have done pretty well when it comes to the coronavirus?
All right, thank you so much for having me once again, and my greetings to Prof and David, my colleague. There is an unanswered epidemiological question, which is that exactly how did our first 2 patients get this infection? And it's interesting that we have two different individuals from different locations reporting to the same hospital with the same condition. And that's how come the diagnosis was first made from the same hospital. One was subsequently, body was sent to Savannah region where the person it actually hails from. So the epidemiological question that remains unanswered is, where did these people get the infection from? As present, there is no travel history. So we cannot suspect that they got this from somewhere outside this country. From the information we have from the clinicians on the ground and those who visited the place, none of these people had had any recent travel outside of the country. So most likely is that they might have gotten this infection from animal sources or animal reservoirs like the fruit bat. But could it be that both of them were exposed at different locations to the same bat, or what is the situation? These bats are found in mining areas, in caves, and things like that. So coming in the Ashanti region, in a forest area, yes, there could be that suspicion. Data available in this country suggests that there's been some earlier studies that have shown presence of these bats, these antibodies to this Marburg virus in some animals in this country. And that has been proven. But we have never had a clinical case recorded. So a lot of questions, unfortunately, the index cases have died, so no more interrogation can go on. But a lot of questions remain unanswered as to how the first people got it. So that background, therefore, tells us that we could not have gone to sleep because it's not an importation. It's not likely to be an importation that caught us unawares. And if you look at the nature of this condition, when it first came in Guinea, it was also the same. The first person to get it was the only person, and he died, and that was it. It didn't spread any further. Unfortunately for us, it appears that in our case, there's been some human-to-human transmission, because the wife of one of the index cases is a suspected case, and there's been reported death of a child by the WHO of the index case, which will mean that there's confirmed human-to-human transmission within our community. I would join Prof in commending the health service, because I think the clinicians and public health physicians, nurses, health assistants, the laboratory people did excellently well, in the sense that when you have never diagnosed a disease in your country before, you need a high index of suspicion to even make the first diagnosis. So to the extent that they made the diagnosis, and to date, no health worker has been confirmed ill, would suggest that they obeyed the basic infection prevention mechanisms in the handling of these first two cases. In fact, initially the diagnosis eluded some of them, and later the suspicion came. One of them was actually managed as a bleeding disorder. They were not sure of what it was, but they obeyed all the infection prevention protocols. And it's the reason why, thankfully, we haven't had any doctor, nurse, laboratory person dealing with such a dangerous organism coming down to the disease. And in terms of our public health response, I think the response was swift. Localized public education took place. Samples were taken, followed the international reporting protocols, first tested in Noguchi and secondly sent outside of the country for confirmation in the WHO-approved laboratory. And I think that response has been okay. Contact tracing was also okay. I think we, the community members, did not do too well in some point. I'm sure maybe when the health service join us, they may give the challenges they had with maybe the disposal of the dead whilst they were waiting for the confirmation of diagnosis, how these things happened. A bit of it leaves much to be desired. And it's the reason why public education like this is very important. So the approach, as we understand from the association, was that let's do localized containment. Let's trace all the contacts. Let's educate the community. So a lot of education took place in the communities that were affected. But it is important that once this has gone beyond one region to two regions, we need to do national education, which is what I think your platform is doing. On the part of doctors, the infectious disease unit in Kolebu. They came up with a presentation. I took part in it. I listened and studied a lot to inform doctors about it. I know the Ghana Health Service issued a release to all health institutions defining the case, what the case definition was, and what we should look out for. Marburg is deadly, as has been alluded to by Prof. and by David. It's like a senior brother to Ebola. And with no vaccine in sight, with almost 100% case fatality, it's reported as 88% in some places. That is quite high. Very few people survive it. But the good news is that it doesn't spread that easily. And usually, you need very close contact. Be in the same room with the person, touch bodily fluids, spend considerable time, and it's not spread in droplets. So it's easy to contain, but we do not want a widespread community spread because of the deadly nature of it. So I think we've been up to the task. There's so much to be done, especially in risk communication, informing the public, and then putting a lot of other things in place, which I think we will discuss in the course of this presentation. But I'm very comfortable, let me say, with the initial response of the Ghana Health Service and those managing this outbreak.
When the coronavirus, for instance, entered our shores, there was a major concern many shared, which was that there seemed to be less focus on the already existing ailments like malaria, HIV, etc. Now there was 100% focus or concentration on how to deal with the coronavirus. Do you get the sense that we need to probably start shifting that kind of concentration and focus on the Marburg and the monkeypox? And then what happens to the coronavirus? Very little has been said about it in the last few days, when these two other viruses came into the system.
Yeah, so as you can see, we are plagued with three diseases of public health concern or emergency state. In fact, in the case of coronavirus, it's a pandemic declared. We all know that. Monkeypox is almost at that level now, spreading in several countries. But the difference between coronavirus and this was that coronavirus was very novel. We did not even know how this thing spread at the time. We were not sure how to manage. Every treatment was experimental, was spreading very rapidly. Attack rate was very high. And unfortunately, was also associated with mortalities or fatalities. So that made a lot of panic in the system. There is a lesson, a very useful lesson we learned from Ebola when we sent people to help in the countries that were plagued with Ebola, our neighbors. And one of that lesson is that when you cause mass fear and panic in outbreaks like this, people die from conditions other than the disease. And in the case of Ebola, I'm a gynecologist and obstetrician. Look, women even had normal menstrual flow and no doctor was willing to touch them because any bleeding was suspected to be Ebola. And once you got touched in contact with the patient, the transmission was very rapid. And at the time, people were dying rapidly. A lot of doctors were dying, nurses were dying. So you have any bleeding disorder, you get to the hospital, everybody's scared to touch you unless you report to a center where people are well gowned and ready to take care of you. And if you listen to the stories in those countries, a lot of the people who died from other conditions that was not Ebola at all. So we need to manage the communication well. Yes, we need to devote resources to the outbreak of Marburg. We need to devote resources to the control of monkeypox. Monkeypox is not very deadly. Unfortunately, we have reported one death. But if you look at the global picture, people are getting a lot of cases, no one is dying. There may be other reasons explaining our death. I'm not sure. I'm not brief on that. But there are still road traffic accidents killing us. There is still malaria killing us, typhoid fever, other conditions. So we need to balance it. If you look at COVID, when we had the outbreak and we're struggling with ICU spaces, there were lockdown, the number of people who stayed at home, who needed hospital care, was significant. I mean, I heard of a harrowing story of a patient who was pregnant. There was lockdown. She needed to deliver. She could not get a car. She had to walk to the nearest facility, which is not where she attends clinic normally. How she was catered for there was another issue. And all this because of the fact that the system was stretched. We had to stop elective surgeries because of COVID, because a few anesthetists and intensivists were involved in the care of COVID at the isolation centers and the ICUs. But that is not a proportion that we have now. It is the reason why I think public education is useful. We need to educate the public, but we need to contain this disease in the areas where we have it and not shift our entire global or national attention and resources to this disease and let people die even before the disease gets to them. The disease is deadly, and so we don't want it to spread. So let's contain it where it is, do the effective contact tracing, supportive care to people who have it, provide our PPEs for the nurses, for doctors, for everybody involved in the care, in the hazardous laboratories that are going to test this, protect them adequately. But we must still keep the ball on COVID because COVID spreads easily than Marburg. We must still keep the ball on our focus on monkeypox because monkeypox also spreads with contact and not as deadly. So I think we need to balance it and we don't have to ignore the rest. Right. COVID, fortunately, now we have a vaccine. And the GMA, the nurses, David is part of it. We, together with the Ministry of Health, with a project we call the Resolve Project, we are educating the nation against hesitancy of the vaccine so that as many people can take the vaccine, should take it, so that is not part of our problems. But our public education on Marburg is useful because the contacts are being traced, and the fact that we don't know how these first two people got it means that somebody else can report of a case somewhere else, and we should not miss it, because once we miss it and it spreads within the community, the fatality is very high.
Okay, thank you for your preliminary submission, Dr. Bayo. Let me come back in studio now and come back to you, Professor Benka. To start with, give us a bit of background of especially the Marburg virus, which, you know, you've just said that and has been established that its death rate is quite high. We know that in Ghana, is a suspicion by the medical officials that it came from a bat or a fruit bat, and it got to probably a first human. Give us a bit of understanding of how the spread is like. And do we also have issues of someone could possibly have it but be asymptomatic, like the coronavirus, where someone can have it but not show any symptom? When it comes to the Marburg, is it a possibility?
Yeah, so thank you very much. And let me support the contributions from David and also from Dr. Bayo. They've really covered a lot of grounds. Now let's focus on the Marburg itself. The problem we have with its transmission to today is based on whether we already have had it in our system. There are reports that in the past we've had bats, people have done some work in bats and they've recognized that this exists. Number two, it's also occurred in Guinea. Guinea is not so far from us. I used to also figure out that Guinea was far until I realized that with the advent of motorbikes, there are many people from Guinea who come with motorbikes into the Brong Ahafo region to mine.
Really?
Yeah. So they don't need to go by air. They come on the motorbikes and they're able to go very fast. So the issue that we don't have now is what I was just saying, that we need to do some active surveillance to find out how many people have been exposed. The epidemiology of this is very clear that normally we don't have people who get the virus and don't show symptoms. They are not the asymptomatic type. In fact, if there are asymptomatic people, they are very rare and they are few. Okay, it's not like COVID where about 80% of people will have it, but will not be symptomatic. So that's where the difference is. Number two, if you get it and you get symptomatic, the chances of survival are virtually nil. Okay? I think what makes it easy is that, well, let me go back and say, so the fruit bat has the virus, human beings eat the fruit bat, and maybe they didn't cook it well or so, they didn't kill the virus, and the virus gets into man. Okay?
Is that the only way it gets from the bat to human.
No, the bat
By
could also
consumption.
bite you.
Okay.
You know, the fluids of the bat and all these things, it travels in the body fluids. When I come to man, you see that it's the same.
Okay.
So when you deal with the bat, maybe you catch the bat, it bites you, it can transfer the virus. It's the same way in human beings. When human beings get the Marburg virus, it goes through the blood. If you come into contact with the blood, the body fluids, the clothes that they wear, if you are in close contact with them, and the body fluids includes, they have a lot of diarrhea and so on, and if you don't take time, you could get exposed to that. But what makes it, what gives it away is the hemorrhagic part of it, the bleeding. Our people are very, very conscious about bleeding. Anything that leads to bleeding, people stop and say, hey, if you just got bleeding from your nose just now, people will avoid you. But it's the bleeding that gives it away very quickly. The other symptoms are like malaria and other things, weakness, fever, and so on. But also, with Marburg, you can also transmit it by, the dead people can transmit it because they are body fluids. But it's not like COVID where it's through the lungs, okay? So it has those areas, and that is where we have a problem. We are enamored with the dead. When people are sick, we all come together and try to help the people. So we get into close contact, and then we can transmit it. The way this has happened shows that this has been here long ago, because the transmission from bat to human is straightforward. It's the bat that is having it. Humans get into contact, and then it transmitted. But the man-to-man contact doesn't happen overnight. You know, the bat has to develop that process of being able to transmit it from man to man. And once it has crossed that barrier, then we are, I would say we've lost it. We are not able to put it, if we knew that it's the fruit bat and it's not transmitted to man, the first thing man will do is to go and kill the fruit bat so that it doesn't get to human beings. You saw SARS and all the other ones. They kill the piglets and so on to protect it from moving to man. But now, if it is man to man, that's a big problem. And our problem now is, as Dr. Bayo said, what exactly happened? We have two regions. We have two people. They didn't travel outside the country. And the family one is the one even that makes it more serious, that the child of the person who died has also died. And I think the wife has also been infected. How could it have been only them? You know? So that's where the problem is. I suspect that there are other ways in which this thing should be investigated. And one of the ways is clearly we have to blanket that area. We have to do blood samples. We have to check who has come into contact with the virus. And we have to map that very quickly. Otherwise, it looks calm now, but remember that it could just explode. There are many people who have been in contact with these people, and before we realize, we have a big, big problem on our hands. And the Marburg epidemic will be really very difficult to deal with.
Right. Yeah, and that brings me to you, Mr. Tinkran, the personnel and then the dealing with it. So far, what can you tell us about how it's been dealt with, the personnel you've deployed who are there? How are they managing the situation, especially after they've undertaken some contact tracing as well?
All right, thank you. Well, I think that, as was earlier on alluded to by my co-panelist, the public health personnel were able to deal with the issue as quickly as possible. Initially, I think about 100 people were rounded up, out of which 40 were health workers and 14 were nurses and midwives. And none of the nurses, after 21 days, have shown any sign of the disease, which is good. So we need to continue to pursue the issues. In fact, we have to streamline a very containment response, because like the way we adore the dead. If you are not careful, we will have issues. Yeah, because I mean, if somebody dies and you see people sitting by them and fanning them. So once we're able to embark on active surveillance and detect or test as many people as possible, like what we did in COVID.
Yeah.
You understand? There was that active surveillance, there was that contact tracing. We were able to round up a lot of people. And so we shouldn't be chasing the virus, right? So we should go ahead of the virus. If you're able to do that, then we can eliminate it. But I think that the health workers have done tremendously well. And I need to single out Dr. Asidu for mentioning. I heard him a couple of times, talking on radio about the measures that they have put in place to be able to deal with the issue. And I believe that the nurses and midwives must also be trained. We are in collaboration with Ghana Health Service and GMA, as mentioned by my brother Titus, to train some vaccine champions and all that. And I think, Titus, we have to include the Marburg and the monkeypox instead of perhaps leaving it to that of COVID. We are trying to educate our members, train more vaccine champions to be able to educate nurses and midwives so that we can increase the uptake even among health workers as well as the community. And if we're able to put COVID down, then we can attack the rest of them. But we shouldn't wait. We have to have a composite response management to be able to deal with all these three issues. One difficult aspect of Marburg is that it's a hemorrhagic disease. And several diseases mimic its signs and symptoms, like even typhoid or malaria. So by the time it gets to where you are seeing major signs like bleeding from orifices and venipuncture sites and the rest of it, it means that the case is getting to its severe end, which might not be because you deplete a lot of, once you are bleeding, you are going to deplete a lot of clotting factors and other even conditions can set in. So it is something that we need to mobilize resources. And I talk about resources because public health funding is underfunded in this country. Let's be frank. At the clinical area, because of internally generated fund, because of maybe health insurance, they are able to mobilize some resources which may not be even enough to take care of clinical practice and the rest of it. But when it comes to public health, if we don't direct specific resources, we will have issues. You can find out from our disease control officers, our nurses, whether they have had any serious surveillance, if you like, education. Maybe it could be some passive surveillance or maybe some Zoom conferencing or something. We need to move down to the area and educate the people very well. So we need to provide a resource because I'm taking this from the outbreak of COVID. We had to impress upon government. We needed to put pressure on the employer to be able to provide basic logistics. And as I keep saying, we spent quite amount of money in fighting COVID, but did we direct it to the fight itself? No, we need to prioritize the issues. Of course, we need to feed people when people are under lockdown, but is that our priority? It's important. I'm not saying that, I'm not discounting the importance of it, but I'm saying that, look, let's direct the money to the areas that it matters most. Then we can use the SSs to take care of other ancillary issues. But if we don't fund public health, we have issues. Because I'm yet to see any serious workshops being run in person, for health workers. I mean, Dr. Titus mentioned one, which was done, I think I nearly even attended that workshop. I had other things to do. Right. So I think that we need to be able to work it out. But I'm very confident. We need not to be fearful. We just have to go by the dictates of the experts, like what revered professor has laid out. It is easy to detect, and once you see something, you say something.
Say something.
Yeah, yes. It's not sitting down for the thing to go berserk. So that is what I'll say for now.
For now.
Right. Can I add a little bit?
Yes, before.
I think that we should also, thankfully to what David said, we should also remember that the COVID has helped us a lot. Because now we have the infection prevention methods around. When the nurses and the health workers see cases of fever and hemorrhagic bleeding, they will protect themselves. So I was so happy when Dr. Bayo said most of the health workers who were checked, none of them had got infected. Yeah. So that is a big thing. It wasn't so in the past. But today, when our workers see these things, they are able to say, hey, let's get our PPEs before we get involved in the with the patient.
Fine.
But where the loophole came was that the patient was buried. That's
in the case of the Marburg death.
That worries me because the body should have been kept till the diagnosis was finalized before the action taken. You could imagine what happened during that process. Maybe we are lucky nobody got infected.
Right.
Yeah.
When we return from this quick break, we will definitely be looking at how we can retool and resource. I mean, that's it looks as if that's the standout point for me from the submissions, that we really need to resource our health personnel in dealing with the further spread of the Marburg and the monkeypox, while we are still doing what we can to make sure that the coronavirus is still kept under wraps here in Ghana. Stay with us. We'll have further discussions on this particular subject after this break. You're watching TV3. This is The Key Points. You're still watching The Key Points on TV3, and we are going straight back to our conversation having to do with health, which should be of a concern to you watching us right now. For this segment, I'm going to start with Dr. Bayo. Doc, I recall that when Liberia, Sierra Leone, and some other West African, in fact, other African, and Guinea recorded the Ebola virus, which was quite fatal, we sent some Ghanaian, health professionals there to help and then also get some training on how to deal with it should it ever enter our shores. I believe now that we have a Marburg virus, which we are told is the senior brother of the Ebola virus, that training should come in handy to be able to help us in effectively dealing with it. No?
Yes, I think it has been helpful. And I think God has been gracious to us as a nation. Ebola passed us by. Some of us said it cost us over as a nation, but we learned a lot from it. We serve as a coordinating center. Our EOC was established. We learned a lot of lessons. In fact, some of our first PPEs we used during COVID outbreak were leftovers from Ebola that we gathered in case a case came. And then we didn't get a case in country. And then we mobilized immediately, the COVID came. And it was very helpful. Then we had an unpleasant visitor, which is COVID. Again, we learned a lot from it. And all of that is what has culminated in our good response to a very terrible infection now, which is the Marburg. And the level of preparation that the health system has had, unfortunately, I don't think the community has had that. And it's the reason why I think that health-wise, health system-wise, in terms of health personnel, a lot of our people are trained, at least are aware, know the symptoms, know what to do. But the community response still leaves much to be desired. I mean, I just want to go back briefly to what Prof was touching on. I alluded to it earlier in my submission. If you look at the case that they took to Sola, the person was buried even before the diagnosis was confirmed. Okay. And I'm picturing that should this happen in my hometown, what will happen? I come from a district that has a very strong Islamic community, the Lambuse district, and a Christian community. And I've daily, sometimes, often I have to call hospital to engage with my colleagues on release of body. When somebody passes away, the pressure that comes to bear for religious reasons, that people need to bury the dead according to religious and customary demands, and they need to do so within a short period of time. This was the challenge that resulted in this patient being buried even without the diagnosis being confirmed. And that increased the number of contact tracing, people that needed to be traced in the contact tracing. So the community needs to come along. The population needs to come along. We have been trained. People have been able to work in the very dangerous situation of Ebola. We just didn't go there to understand it. People actually went to work. And when COVID came, you saw that people were able to stand up to it. We knew how to don and doff their gown and everything that we needed to do to protect ourselves. And we are doing so well. But how well have we involved the community? Remember, there is an unanswered question. how did index cases 1 and 2, the first 2 simultaneous cases that are reported, how did they get it? Once that remains unanswered, it means that it can appear anywhere. And if it appears today in my village in Kocha, the likely thing is that they will want to cry and bury. So, and if somebody dies of a bleeding disorder and didn't have an opportunity to get even to the hospital to be tested, how do we handle this? How are we getting the community informed to know that, look, we have this outbreak that we've not been able to explain how the first person got it, and therefore, if you have a patient who has A, B, C and dies, please get the health system informed. Even before, how do you handle the person? At least minimum, people could even use gloves. If they don't have gloves in the community, they can be advised to put on even plastic bag on their hands to handle the dead to the nearest hospital for proper testing, for proper history taking, for us to check if it meets any of the case definitions. That bit, I think, is lacking. So the community engagement is my biggest concern. And I think that we have to educate everybody, religious leaders. We need to understand. I mean, I only got to know that even Islam does not frown on autopsy or postmortem. It is nowhere in the Islamic dictates that postmortem should never be performed. But our level of engagement and education for the people to appreciate that, look, okay, this death may be normal, you can bury according to your tradition. This one, no, we have to think twice about it. We need to assess it so that we don't endanger you yourself. Then they would appreciate it that you are trying to protect us, you are trying to protect mourners and all. So my biggest concern is the community engagement. Okay. And to the extent that everybody is updated, everybody is informed, people don't go touching the dead with their bare hands. We are talking about fruit bats. There is evidence that some fruit bats in this country have borne this virus before. We need involvement of the veterinary services, the wildlife division. Can they do a surveillance of the bats available? Do we know how many of them may be carrying and which location, geographic location these bats may be that may be harboring this? If it is so, how do we cut that transmission from that level? Because this is sporadic. It can also appear anywhere else to somebody else. Right. And if that is the situation, how do we go around it? So that is a level of engagement that I think we should do. And maybe towards my final submission, when given the opportunity, if I want to go into a local language and talk to my people about this.
Maybe you should do that because the time we have left, I'll be giving the rest of the slot to those in studio with me. But I would want to ask a question after which you can do the final submission in the local language. You're asking and advocating for enhanced community engagement. What is preventing us from doing this community engagement? Is it resources or just sheer, lack of knowledge that is a necessary component in the value chain of fighting some of these infections and outbreaks?
So the health service deliberately decided to focus on communities in which this outbreak was, or communities that they thought was at higher risk, and try to contain it at that level. I think we need to step it up to the entire nation, especially when we have an unanswered question. An issue of resources may come in. Also, competing interests are there because we have COVID communication ongoing, we have monkeypox, and we need to add Marburg virus. But they are all important. And to the extent that the transmission, especially the Marburg and monkeypox, are similar, we can do the community engagement alongside. Resources may be critical, and I think that also needs to be mobilized, as alluded to by David, so that we can have enough community engagement. And I think the media must come in. All local stations must come in. Community leaders must come in. And all of us must do so to make sure that we keep the country safe. So I think these are some of the reasons why that is not happening as much as I would have desired. So that when there's a case, we can handle it well. Okay. And if permitted, I can then make a short commentary in my native language to my people.
Please do.
All right. So in Zelenina, Dagarabibi, Nizana Cheleme ya Alampuse, Dia Nandom, Kucha Saint to Zinana Teleme ya Abibarana. abalona tina yele bebola mabek barosa ola wanyo ne sala zimi chile naso so kapa nyela beba zina bebe ola wa chen bandira zina bena bandira po funwanya ana toso fundir wa biere aji awatera ana tabe ewa pia nita pa akun a fonle nita nyowa somni nuzalai nita so tane hospital abeton ka abambone na noa so that anina bebe ala iyeza abalota lori anyonye ani chazene fan ne barka. Thank you so much for the opportunity, and once again my regards to Prof and David, and I hope that media general you keep up this education so that we keep the nation safe.
Nebarka. Thank you so much as well. All right. So Dr. Titus Bayo is the General Secretary of the Ghana Medical Association there. I mean, that's a call that has already also been reiterated by the panelists in studio. Maybe I'll come to you, then we'll wrap up with Prof. The concern he raised about the public education, community engagement. I mean, many thought that it was already in place. We already have such a system of getting people to know about the already existing ailments where we talk about malaria and what to do to prevent it, the known ones. But for this, is it that we need a different scheme, a different approach to, because there are also novel and new, conditions that we are recording in Ghana?
Well, I think we just have to coordinate the responses, basically, because, of course, they are new, and we should let the people know that it's dangerous, but they shouldn't be fearful. All what we need to do is that we have to avail ourselves to the necessary information and apply ourselves to the dictates of the epidemiologist or those who have the knowledge in that area. Yes, and when it comes to competence of health workers, we don't have a problem with it. That's why we're able to send our own generals to Liberia to fight Ebola. So if we could avail ourselves to fight Ebola outside Ghana, it tells you that the Ghanaian nurse, doctor, lab technicians is ever ready to fight for Ghanaians. I would prefer to fight for my fellow Ghanaians than go and fight for somebody else. So we are ever ready. What we need is resources to be able to fight the infection. And these resources will come in various forms, including capacity building. We should be able to build the capacities of our nurses and doctors and provide the necessary reagents, okay, to their various laboratories so that they can test the stuff. Despite the fact that we sent some of the samples to Senegal, it was picked up by Noguchi. It tells you that we have a reference lab that is capable of doing the job. So what we need to do is to provide them with the necessary resources. My attention has been drawn to the fact that even the district that recorded the Marburg, not much resources have been directed there.
Although they were the first.
They were first to detect that. We need to do that. I mean, the nurses did fabulous job because I think it was picked at the chip center or something before it was referred. Exactly. And that should tell you how their knowledge level and how good they are. So we just have to help them so that they can do justice for us. As far as I'm concerned, we have what it is to be able to deal with the issues. All what we need to do is to get government, the ministry, the sector minister to come in handy, you understand, to assist those who are fighting. I mean, Dr. Sidu Bequin, the Director General, they are doing fantastic job. Right. And what we need to do is to give them the necessary support in terms of resources, not just verbal push.
Isn't the word resources too broad? Can you be a bit specific? If you say the health professionals need resources, what are some of these resources? Maybe brother, top 2 or 3.
They need money.
Okay.
They need money to be able to move. They need logistics. For instance, the PPEs and the rest of them must be readily available. We shouldn't count gloves. We shouldn't count masks to people. I hope you understand. I mean, I'm told when COVID reared its ugly head, we were counting gloves and the rest of it. You don't know the number of people you are going to attend to. And they have counted gloves or they have counted masks to you, for you. How are you going to be able to effectively use some of these? So they should provide money and other logistical resources that can be applied in solving the pandemic. Once we are able to supply those things, I believe in the competence of our health workers, and we'll be able to nip this in the bud.
Okay, I'll bring in Prof. My last question to you would be the role of the citizens. Okay. Because we almost always shift the attention to what government should do, what the health professionals should do. But then we who are the receiving end of this assistance also have a role to play. Can you briefly outline, what our role to help those that are helping us?
All right. I mean, the citizens must be responsible. Of course, they shouldn't sit back and watch the healthcare providers. They have a responsibility for themselves and their families. We have been able to isolate the causative organisms. Of course, I mean, when it happened in 1967 for the first time, we traced it to a lab work where in Marburg and Frankfurt, people were working on some green monkeys that were imported from Uganda. This time around, we think that it's the bats which is spreading the disease. So we need to be very careful. Those who move into capes, the Kwao area, I'm told that there are some capes in Kwao area. If you are going there as a tourist, you must be in mask. And you should be very watchful so that you don't get in contact with some of these bats and stuff like that. Don't you think? You know that bat is a very good delicacy.
It's a delicacy.
So I need to educate my brothers and sisters. I'm from there. They need to be extremely careful. If they want to cook it, they need to cook it well and make sure that it's well
But
cooked.
does cooking kill the virus? Yeah. If you cook the bat meat, does it kill the virus?
Cook it well.
If you cook it well, yes. I mean, you are good to go. But I mean, if I were them, I would rather avoid it in the first place because we have several other things that they can take. So for now, once we know that there is an outbreak of that nature, they can decide to forgo it and apply themselves to other meat or other protein sources so that we can have a good play. But the citizens must be aware. As I said, they own themselves a responsibility to remain alive and all that.
Okay.
Thank you.
Prof, I'm giving the final words to you. First of all, maybe you can help us. What exactly is causing that in the last year and a half to two, globally, the number of viral cases, the number of medical issues seem to be increasing? What could be the underlying factor behind this? Then maybe you can wrap it up with Ghana's cases.
Okay, so that's a very good question, and that's one of the problems that Ghana faces. I think we started with Ebola. Let's put Ebola aside, but let's come back to COVID. The COVID pandemic has raised huge awareness around the world. Our diagnostics have gotten better. We have many ways in which we can test and to be able to detect these viruses. So a lot of testing is going on. In the advanced countries, almost every house has a rapid diagnostic kit for COVID, although we don't have that here now. So the testing is going on. And most of the time, when you are doing this testing, you don't test for only COVID. You empanel several other diseases to find out who are in that group. Okay? So the testing has improved. And it's gotten very sophisticated in such a way that almost everywhere in the world, you can find people who can test. Marburg has not been here, but when it arrived, we were able to do that. And there are many more institutions who will then learn from that. So that's one. The second issue is that I want to put this back into, in my concluding words, put this back into the way we are approaching this. I will come and talk about logistics. So at the moment, what we are doing is we are doing this passive surveillance. It's like the fire service. The fire service is there with its water and everything. When you say the fire is here, they go rush there and put it off. Okay? They lose all the properties and we don't actually benefit. We can't afford to do the fire service type with human beings. Are you getting my point? We don't want to arrive and the people die. We have the capacity now, the knowledge, military people, to protect people. And that's what we should be doing, getting ahead of the virus, finding out who are exposed, who are at higher risk, so that we can deal with that issue. And it includes all what you said, community participation and informing the community, looking at the health workers, providing them with their needs, PPEs. You see, you say, oh, there's no COVID anymore, so we have not sent PPEs. But when that febrile illness with bleeding arrives and the staff at that center did not have PPEs, they would have got infected and they would have lost their lives. Okay, and they'll be hesitant to try and deal with this thing. So I think we need to look at those resources. Fuel, reagents for testing. And then when you say reagents for testing, it means that there should be another round of improving on the capacity of the labs to do a good job. Okay? Noguchi just showed that it does a good job by asking another lab to check what it has done. Okay? That's the kind of thing that we are saying. When these things happen, we need to improve on the human capacity. We need to have the prominent people to get engaged in all of this. But what are the churches doing? Have they told their people about what is going on? Have the mosque been involved to talk about this issue? And if without that awareness, we will not detect this, what is going on. It's not going to be a label on somebody's forehead. So let's come out. Let's make sure that we are engaging the public. We are talking about it. The good news is that our health workers are capable of trying to protect us and deal with the situation once we find it. But if we don't help all of us and the resources, have you checked at your district hospital whether they have PPEs?
That's a question that we, those watching need to help us answer. But finally to you, Prof, again, would you advise that, considering what's happening now, we should place a ban on bat meat consumption for now? Maybe when we are out of the woods, then we can go back to enjoy, because it's a major delicacy, I know, in some parts of the country.
Yeah, so personally, I get proactive about these things. This disease is deadly. You know, if you get it, the chances of surviving are almost zero. Don't worry about 88%. You know, so if that is the situation, then based on that evidence, I think we should take a break. You know, let's take a break. Let's protect ourselves. Let this wave pass by, and we can come back and eat the bat meat. Otherwise, we might die
while
enjoying the meat. So let's take a break and try and make sure that we can control it.
Okay. Yeah. Thank you so much. Professor Fred Newton Binka is an epidemiologist. The word keeps slipping out of my mouth. An epidemiologist with the University of Health and Allied Sciences, UHAS. We also have with us David Tinkron Chum, General Secretary of the Ghana Registered Nurses and Midwives Association. Dr. Titus Bayo joined us via Zoom. Our conversation was focused primarily on the three major public health concerns that have been raised in the last few weeks, having to do with the coronavirus, which we are hoping that at least now that the numbers are low, we'll be able to deal with much more decisively. Then we have the Marburg, which has a fatality rate very, very serious, which has been clearly mentioned here that the rate at which it takes lives is cause for concern, for which reason many more resources or much more resources need to be channeled into public education, awareness creation, and prevention. And also the bit about the monkeypox, which although isn't as fatal, has its own implications. And when you get infected, we as a people have a role to play in making sure that we first of all do not get infected, and then also help our health professionals who've been deployed to our various communities in educating us and helping us live better and healthier lives. That's how we bring today's edition of Key Points to a close. A big thank you to our sponsor, Niche Choco Drink. And as I mentioned, if you're having breakfast today, if you haven't yet, you should grab one for yourself and for your kids. It's very nutritious. It's a taste of Ghana. Let's support good quality brands from Ghana. My name is Martin Asiedudati. It's been a pleasure sharing your company for the last about 2 hours. Up next is Kids Arena. Stay tuned to TV3. Bye for now.